to today's lecture. I think people might be finding this place. I certainly did. So I'll talk, just waffle on a little bit while a few more people to come in. As you all, I guess, probably know, the International Decision Support Initiative, whose board I chair, has as its central purpose giving advice to low and middle income countries on how best to prioritise very limited resources. And our work involves not only sort of quite a lot of technical stuff, in making investments, but it also has quite important implications for how decisions are made, who's involved in making decisions. And our work has been enormously influenced by Professor Claxton's work. I think to say that without him, we would not be as good as I think we are. So that's one very good reason for being delighted to have him here. But there's lots of other good reasons as well. He is famous for quite a number of major achievements. The latest Bible on how to do this sort of stuff, cost effectiveness, cost benefit analysis of healthcare, is essentially his book, a new edition of the one that was edited by, formerly written by Drummond and colleagues. And that's if you haven't read it, that's a real tour de force. It's quite technical, but it's also quite readable, which is a combination not always to be. Another very notable thing that Karl has done has been to make the only really comprehensive and credible estimate of what the NICE threshold ought to be. And that was a major tour de force, both conceptually and in the empirical stuff that he did. More fundamentally, he's been very instrumental in developing what I call extra welfare economics, which is a way of doing health economics that liberates from Marshallian triangles and cost-benefit analysis and essentially reliance on fickle preferences of individuals. And he's really made a huge contribution to that. And also related to it, the ways in which decisions are taken, the importance of deliberation, the importance of involving stakeholders of all sorts, all kinds, in various stages of the process of decision making in low, middle and high income countries. So all of those things I think are pretty wonderful, and I think taken as a whole make him the best health economist that we have in the UK at the moment. So it's a great privilege to have him talk to us, and I'm sure we're going to be both entertained and informed. So his topic is here, informing decisions in global health. I think the focus is going to be on low and middle income countries rather than rich countries. Karl.
Thank you so much, Tony. It's a real pleasure to be here. Thank you for the invitation and thank you for coming. That's a really kind introduction from Tony. Tony taught me undergraduate micro. He was my head of department, been my mentor throughout my career, and I wouldn't have a career without Tony, so kind words mean a lot to me. We stand on the shoulders of giants, and Tony is one of the giants, and so that's great. Tony's an excellent chair, and gave me a detailed briefing a couple of weeks ago by email, because I think he was in Canada. He said, "Dear Karl, I'm chairing this thing, so make sure it's good." Which was absolutely spot on, succinct, clear. It reminded me of the best review of a paper I've ever had, which was also from Tony. It was the best and the shortest. It said, "Dear Karl, I like the paper, at least the parts written in English. Do recall, a good idea badly expressed is simply a bad idea." So, succinct and clear is what is required. So, yes, making decisions about healthcare. What do we need to know? What do we need to know to make a good decision about healthcare? Well, we need to know what we think the additional health benefits and the additional costs of a proposed investment might be. That might be an investment in a new technology, a drug, an intervention, or a whole programme of care. So if that's what we need to know, we need a couple of things. First of all, we need a measure of health benefit. If we think the primary purpose of healthcare expenditure is to improve health, we need to be able to measure health. Remember, I say primary, it's not the only reason, but it is a primary reason. What kind of measure do we need? Well, we need a measure that will capture impacts on survival and the quality in which those additional years of life will be lived. It needs to capture at least those two elements. We need a measure that's comparable. Why? Well, some interventions have impacts on many different diseases, so we need a comparable measure across disease. The second reason is that if we're going to make these choices, social choices on others' behalf, they've got to be fair and comparable and reasonable, and therefore everybody's got to be treated in the same way, so we need a comparable measure for that reason. And finally, we need a comparable measure because actually the resources are resources that could have been used to offer care to other patients with other diseases. Every decision in healthcare requires us to compare benefits, health benefits across very many different disease areas. So we need a measure that can do all that. We need a generic measure of health. And we've got a couple available. In terms of low and middle income countries, we've got disability adjusted life years. I'm more used to QALYs, but you know, you say DALYs, I say QALYs, call the whole thing off. I don't think we need to call the whole thing off. You know, there's important arguments about how to measure health, but at the end of the day, what do we need to know? DALYs are bad, you don't want them. QALYs are really good, you want as many as you can get. Okay, so done. We then, once we've got that measure, we need to be able to estimate the likely effects on health and costs, and that's kind of going to be uncertain. We're going to have to combine evidence from multiple sources, and we're going to combine that in a sensible way, often using decision analytic modelling that can get really quite sophisticated. And we've done a huge amount of work in these two areas, how to measure health and how to combine evidence and establish the costs and effects of the alternatives available to us on the table. I've been involved in that, the whole field has been involved in that. We've done a really good job. We've advanced the field and methods considerably. And we need then to report it in some summary way. And the common way in which we summarise things is in terms of their incremental cost effectiveness ratio. In other words, how much do you have to spend on this intervention to get me one QALY or avert one DALY? A cost per DALY ratio. That's pretty much what we do. The problem is, it's not really enough, because what else do we need to know? Well, if we're going to make a decision, we need to figure out, is the cost per DALY averted by the investment on the table worthwhile? Does it represent good value for money? Should we say yes or not? And to do that, we need an assessment of something else. We need an assessment of what else we could have done with those resources. And that's true whether we're increasing expenditure or trying to find that money from existing commitments. If we're increasing expenditure to accommodate this new investment, what we need to ask is what are the health effects of the other things that we could have chosen to do with that new money, or others would have done with that money if it had been made available to everybody else. If we're going to have to accommodate these additional costs from our existing commitments, then the question becomes, what are the health effects of those things we will have to stop doing as a consequence, or others are likely to stop doing if we have to make those resources available from our existing commitments to healthcare? In other words, this is opportunity cost. Opportunity cost is what else you could have done with the money. And this is relevant whether we're increasing healthcare expenditure, whether healthcare expenditure is fixed, whether we've got administrative budget constraints or not. So it's not something that's just relevant to a collectively funded healthcare system like the NHS. It's relevant to all healthcare systems in the world, including the United States. Let me try and illustrate it a bit. I mean, hopefully it's made the point, but let's illustrate it because I'm going to use these examples in a few slides' time. Let's imagine this blue dot represents what we've currently got available. Imagine there's one thing. It might be actually do nothing if we're in a very low-income country. There'll be other things as well, but I'm just going to keep it simple. Imagine there's one. Let's imagine we've gone out, we've systematically reviewed the evidence, we've identified it, we've included it in some swanky Bayesian network meta-analysis, and we've built a model. It's super geeky, we really love it, and we've estimated these quantities. And we estimate that this investment will avert 200,000 DALYs if fully implemented, and it's going to cost, but it's going to cost $20 million. We can summarise that as every $100 we spend on this new intervention averts one DALI. $100 a DALI. Is it worth it? Is it worth it? I don't know. I mean, if it's your DALI, you've got $100. You'll probably pay it, but that's not the point, is it? Is it worth it? It depends where this 200 million is going to come from and what else we could have done with it. So to answer this question, we need to be able to understand or have some assessment of the health opportunity costs in this healthcare system. If we're going to have to find this $20 million from existing commitments, what health are we going to give up elsewhere in the system? What else could we have done with that money? And if we think that health opportunity cost is about $200 per DALI, what we're really saying, we're saying that the incremental cost effectiveness ratio is lower than the threshold, but what does that really mean? Try explaining that on Radio 4, you've got absolutely no chance. What does that really mean? What it really means is that the health that we expect to gain by using this new intervention exceeds the health that we will forego as a consequence of those additional costs. That 20 million we expect to displace 100,000 DALIs elsewhere in the healthcare system. So this is good value. We gain more than we lose. So let's implement it. Let's buy it at that price. What if this intervention, this program was a little bit more expensive for a whole variety of reasons, whether it's acquisition prices or just more costly in this particular setting? Let's say it now costs 40 million. In other words, it's now $200 per DALI. It's the same as our cost effectiveness threshold or representation of health opportunity cost. What does that mean? It means that the gains are exactly matched by what we're going to displace. There's no net health benefit. In other words, 40 million represents the maximum we can afford to pay for these benefits in this healthcare system. If we pay more than that, we damage public health. This also shows us how we can value things as well. Actually, we can express the value of this intervention either as the net DALIs averted or as the value to the healthcare system, the equivalent healthcare resources. This is the amount of healthcare resource. 20 million is the amount of healthcare resource we would have to devote to achieve these net benefits elsewhere. So we can express things either in health or we can express them in terms of the equivalent healthcare resources. Because healthcare systems turn resources into health. And understanding health opportunity cost tells us something about how well it does that. What if it cost a little bit more? Now it's going to cost us 60 million. It's still the same intervention, so we're still gaining, we're still averting 200,000 DALIs. It's now going to cost us 60 million. In other words, $300 per DALI averted. We can only afford to pay 200. What does that mean? If we go ahead and say yes, that means that what we lose, we would expect to lose 300,000 DALIs. We only gain 200. Actually, if we implement this technology at that cost, we damage overall. We're going to lose 100,000. We are going to fail to avert 100,000 DALIs. So, healthcare costs matter because healthcare costs are somebody else's health. So if you care about health and you care about the effectiveness of treatments and interventions, you must care about healthcare costs because they're the same thing. But once we've got this assessment of health opportunity cost, we no longer need to use these cost per DALI ratios. We can express things much more naturally. The net health impact or the equivalent healthcare system resource. And that allows us to do a number of things. First of all, it allows us to think about implementation priorities. Let's imagine instead of the same technology at different costs, which you saw on the previous slide, now imagine we've got 4 different technologies for different patient populations. This is the cost per DALI of each one. This one's great, this one's effective and it's cost saving, so that's fantastic. Different size of population that can benefit. And we can represent this in terms of the net DALI averted if we adopt each of these 4 alternative interventions and the, if you like, equivalent healthcare system resources? Well, it tells us, first of all, we shouldn't be adopting number one. Actually, by approving that, we damage health overall. We can't afford to adopt that, and by doing so, we damage health. Second one here is just cost effective. Just cost effective. $200 a day, about the same as the threshold, so we'll call it cost effective. Well, for sure, but you know what? What's our net gain? Our net gain is zero. This shouldn't be a priority for our implementation effort. We shouldn't be spending a penny on making sure this gets rolled out. There's nothing in it. If we spend any money on rolling this out, we damage overall health. Actually, the one that really matters is number 4 for this healthcare system. Actually, this is where we can really have an impact. The net health benefit is $150,000 averted. It's worth the equivalent of giving the healthcare system $300 million. So, by having an assessment of health opportunity cost, all of a sudden we can start to scale these things in a way that just looking at cost effectiveness ratios just can't. That categorical assessment is not enough. We need to understand the scale if we really want to inform choices about how to prioritise implementation efforts. I guess I said it. Categorical assessment of cost effectiveness isn't enough. We need to understand the scale of the potential net health impact and the maximum amount of resource that a healthcare system might reasonably devote to making sure certain things get implemented. It should devote absolutely nothing to implementing number 2. It should really be focusing on number 4. It's worth spending a lot of money from existing resources implementing this before we start buying it. Let me try and persuade you a little more that we need health opportunity costs. What are the consequences of getting it wrong? If we have a threshold, a criteria to judge cost effectiveness that doesn't actually reflect health opportunity costs, what are the consequences? Well, it means we make decisions that reduce health outcomes overall, exactly the opposite of what we're trying to achieve. We underestimate the value of increasing healthcare expenditure. We actually undermine the project of universal coverage. We reduce accountability for expenditure decisions and donor restrictions. Let me try and illustrate it. Let's imagine we are told that the threshold ought to be $500 a day in a healthcare system, but the truth is the health opportunity costs are $200 a day. Well, on the previous slide you just saw that if that was the case, we would have implemented intervention 1 at $300 a day, and we would have lost, that would have caused a net harm of $5,000 gained. Secondly, imagine we're the Ministry of Health and we're trying to persuade the Ministry of Finance to spend another 10 million. Actually, £10 million would avert $50,000, not 20,000. By getting that estimate wrong, we're underestimating the value of increasing healthcare expenditure. Finally, what if a donor says, you know what, there's $10 million, but it's going to be restricted to interventions which are right on the cusp of what we believe you can afford, because we think it's $500 a day. What are the consequences of that? Well, we get benefits of $20,000 averted. The opportunity cost is $50,000. In other words, there's a net harm of $30,000 that could have been averted because of that restriction. Now, is that net loss worth it? We need to ask the donor. You've got these restrictions. Do you understand that this will cost $30,000? Are you still content that your reasons for restricting these funds in this way are reasonable? They may be reasonable, but they're going to have to justify that harm. I own a website called donorbodycount.org. It's a complement to my other website, which is called nicebodycount.org. I didn't use University of York money to buy those because there'd have been far too much paperwork. I bought them with my own credit card, and a combined cost of £32, which is a total bargain per year, but nonetheless. Haven't quite got round to populating it all, but I do have a vision for what those are going to look like. and they'll be pretty cool. This isn't about telling people what to do or coming up with decision rules. I hate the term decision rules. There is no rule. This is about social choice. This is about deliberative social choices that have to be accountable and legitimate. There's no rule, certainly not a rule imposed by economists. What we're trying to provide is a benchmark, some kind of benchmark, by which we can start to judge and start to come to some assessment of the scale of net benefit for the range of investments and disinvestments that might be on the table. An assessment that reflects what's likely to happen in the healthcare system as it currently is, with its current funding envelope and all its problems and difficulties, but as it is now. It doesn't mean we shouldn't be looking for other unexploited investments that are really valuable. We should. And in fact, as a benchmark, it helps us seek those things out. Is there something else out there that we're not doing that's better than this? Because if there is, let's find it and let's do it. It doesn't mean that we shouldn't be seeking out specific disinvestments to accommodate new ones. But it gives that benchmark for seeking out and asking the question, what is poor value that maybe we should be disinvesting in? In other words, it provides us a benchmark to enable an incremental reallocation of resources over time. It also starts to provide a mechanism by which we can start to look at the value of addressing particular constraints. Constraints that mean cost-effective interventions cannot be fully implemented, whether they're on the supply side, skilled labour infrastructure, on the demand side in terms of access and transport and all the rest of it, or whether they're politically imposed restrictions by donors or political considerations in that particular country. And we can actually start to value those. What are the health opportunity costs of a particular constraint? What could we gain if only we could relax it? What's the value of addressing them? How much of our healthcare system resources should be devoted to relaxing this constraint? Then we can start to really focus on the value of system strengthening and how aspects of system strengthening might be prioritised. We also have a mechanism, a framework, within which we can start to empower negotiations between ministries of health and donor agencies and ministries of finance. It's effectively what's happened in the UK with our work for the UK. The Department of Health uses this work in negotiation with Treasury and the public expenditure round. Don't cut us, we have evidence that we're really good value. And it's not prescribing decisions in another respect. I said that health was the primary purpose, but it's not the only purpose. There are other things not captured by a DALI or a QALY that we care about. We care about equity. We can't quite specify it, and everybody will disagree slightly about it, but we know we do care about it. Financial protection. Again, actually, it's quite difficult, actually, it's financial protection, but nonetheless, we do have a notion that we want to protect people from catastrophic payments. And we also care about the rest of the economy. At the end of the day, yeah, it's mainly health, but you know what? We do need a productive economy because that's the tax base to fund healthcare systems and education systems and all the rest of it. So we care about all these things. How might we deal with that? Well, let's write down the attributes. Let's imagine there's only 4 of them. And let's ask, there's an investment on the table. It's going to cost us $60 million. What do we get from that? Well, if you remember, this is intervention 1. We're going to avert $200,000. Okay? And maybe we improve financial protection. And maybe we improve health equity, and maybe we gain £30 million worth of net production in the wider economy. Great. We need to line that up with what we expect to lose elsewhere as a consequence of that 60 million. Well, we would expect to lose 300,000 DALIs. We don't know much. We need to come to a view about what the effect of health system spending is on equity and financial protection. Let's imagine that we expect to lose £20 million as a consequence of losing. Better than that? I don't know. Well, I kind of do know. If you think this is okay, what you're saying is that $10 million is worth a loss of 100,000 DALIs. Now that's only true if you think a DALI is worth $100. And that can't be true because you said it's 200. So, yeah. But you can see that just setting out what are the attributes of benefit, what are the attributes of what we expect to lose, now you can have a proper discussion about how we might trade in a deliberative process. So I would argue that an evidence-based assessment of health opportunity cost provides clear ethical foundation of including assessment of costs in a decision-making process. I think it makes it more accountable, evidence-based, and that makes it a much more sustainable prospect for all healthcare systems, and I include the UK in that. Should we be looking for, this is what we expect to happen if we just let the healthcare system figure out how to save $60 million. What if we could find something to give up? Well, that's great. Imagine that we go out and we kind of try and find a matching disinvestment that would accommodate this new investment. Well, let's imagine we found this one. And this is like a pretty good category for disinvestment. It's not very good. We only avert 100,000 DALIs. We don't contribute much to the wider economy. It doesn't do anything for financial protection or equity. So, does that mean we should disinvest in this and invest in this? I'd say no, actually. I don't want to invest in this because I think a DALI is worth more than $100, and I want to disinvest in this as well. And that 60 million released, I know, or I expect, will generate a lot more health because I've given more resources back to my healthcare system. So we can use it as a benchmark, but actually we need to have an assessment of, if you like, the productivity of the healthcare system, even if we're seeking out matching disinvestments. Okay. What else? I haven't quite got to the end yet of trying to persuade you that this is a really good idea. I kind of feel like I'm kind of thrashing a somewhat dead horse, but we'll carry on because I think there's some good bits. As we've showed, an assessment of health opportunity cost empirically demonstrates that healthcare system resources are in fact somebody else's health. That's what healthcare systems do. Therefore, we should care about costs, and we should care about prices in particular. How much other people charge really starts to matter. And in fact, price is just as important as how effective the technology is. We can now start to quantify the value in terms of health or system resources of more effective procurement of healthcare inputs. Because if you recall from that earlier slide, we can identify the maximum the healthcare system can afford to pay for the benefits on offer by new technology. In that earlier slide, the maximum we can afford to pay is $40 million to avert those 200,000 DALIs. We can't afford to pay more than that. That's the maximum we can afford to pay. And that's kind of important because it can start to inform us about other policies. That puts an absolute upper bound on any incentives based on payment by results. We're not going to pay more than that because there's no point. We want to pay as little as we can to encourage the behaviour that we think is valuable, but we certainly can't pay more than that. The other thing it does is the maximum that a healthcare system can afford to pay for a drug protected by patent. So if we want to respect patents, or not have to go cap in hand to manufacturers begging them to put it into a patent pool, we don't want to rely on their philanthropy, which I don't want to rely on their philanthropy, but say, you know what, you've got a patent, we'll respect it, and this is how much we can pay. It tells us how much healthcare systems can afford to pay whilst respecting patent protection. In other words, we can start to inform evidence-based tiered pricing globally. Think of these as different healthcare systems. Imagine they're identical in terms of population and the effectiveness of this particular product. The only difference is this one's rich and this one's not rich. And so they've got very different health opportunity costs. The cost per DALI for this healthcare system is very high. The cost per DALI for this healthcare system is very low. Exactly the same product, exactly the same effect, the same population. There is a different maximum price we can afford to pay for this product. Now, what happens at the moment globally? Well, manufacturers basically set a single price, effectively. Okay, it's moderated a bit, but it's effectively a single global price. And they do that to try and maximise their revenue. So let's imagine they set it here. So this product, this is worthwhile for this healthcare system. It's just on the cusp of being worthwhile for this healthcare system. So let's imagine that's high income. This is like below high income or high middle income. But for this healthcare system, it's absolutely unaffordable. And they're faced with a very difficult choice. They either make it available, in which case they damage their healthcare system considerably, or they say you can't have it and restrict access with all the political problems that that poses. What happens? Sometimes donor agencies step in and basically backfill and give this area C, which is a crazy waste of donated funds, because we can fix it. As long as we provide mechanisms for tiered pricing and different healthcare systems, manufacturers would much rather charge this amount in this healthcare system, this amount in this healthcare system, and this amount in this healthcare system. It's good for manufacturers. They take the entire area underneath the demand curve. And you know what? We don't need to use donated funds to fix it. Actually, this area C of donated funds could be put to much better use. Instead of effectively being transferred to the owners of patents, which is what's happening at the minute, we just like give them, cut out the middleman, just give manufacturers tax rates. Instead of doing that, we can actually reserve these donated funds for things that the market cannot fix. If we did this, what would it mean? It would mean that these healthcare systems currently excluded from the market start to participate. Now, will that radically change R&D incentives? It won't radically change them. The US market's massive. But at least they're in the market, and at least they're sending some signal. And at the moment, with effectively a single global price, they're not participating, they send no signal, they have no influence on R&D incentives. So, okay, final bit. Why health opportunity cost matters? Because it's important when we start to think about whether we want to develop new technologies. And this slide deck was partly done for the Gates Foundation, and this part was particularly done for the Gates Foundation, because obviously the Gates Foundation is most interested in using Bill's money to invest in new technologies that are relevant in low income settings. And it's important for Bill that actually his money is used reasonably sensibly, because it's easy to get rid of even Bill's money relatively quickly if you just let people do that. We want to make sure we're using it sensibly, and we're developing those technologies that are going to be of most value in the settings where we want to have the greatest impact. And there, an assessment of health opportunity costs in these different healthcare systems becomes absolutely critical. Same examples that you've seen before, these were the ones for prioritising implementation. Now imagine that they're not technologies that exist, but they're things in development. We've got 4 developments that are in process at the Gates Foundation. We've got a product profile for each one, and we've assessed the costs and the benefits, and we've had a look and tried to estimate our expectations of how effective these are likely to be in particular settings, and how much is going to have to be charged for them. Because Bill funds the development, but he doesn't fund the procurement. And often he's trying to leverage more capital by doing deals with the private sector. So, you know what, I'll put in half of my money into the development programme, you put in half of yours, and then you get to charge a price. So there's a trade-off between how much capital gets levered in and the price that ends up being charged in these settings. Okay? So we've got some health benefits, we've got some costs, we can represent that in terms of ISAs as before. What's the value of the development? Well, the value of the development can be expressed in health terms, or it can be expressed in the equivalent healthcare system resources terms. And as we saw before, for this healthcare system, which is low income, has got very high opportunity costs, so the cost per DALI is about $200, actually, development 1, development 2 is a complete waste of Bill's money for that healthcare system. It's not going to be valuable. It's the development. Where you should be putting your money into this one. This is the one that can really generate value. But of course, when Gates develops a new technology, it's not just relevant to one healthcare system, it's relevant to very many. So we need to do this for all the healthcare systems where the new technology might be useful. So let's have a look what that looks like. This is another healthcare system, a middle income country. Let's imagine health opportunity costs are lower. Now this we can afford $500 per day. It's exactly the same technologies. All that's different is that the population size is different. It's got a different epidemiology. What's the value and what's the priority? Well, actually, for this healthcare system, it's technology 1 that has got the highest value for this healthcare system. Well, it's got the lowest value. Demonstrated quite clearly that using cost per DALI to figure out what is your development priority is profoundly wrong. Look, for this healthcare system, the one with the highest cost per DALI is the best investment in terms of development. The one with the lowest cost per DALI is the worst, because these ratios don't tell you anything about the scale. How can we put this together? Well, we've got value generated in different healthcare systems for these 4 different development programs, represented in health or money. So here we go. These are the 4 different development programs. The global value is the sum of the values in each of the healthcare system, unless it's less than 0, in which case that healthcare system wouldn't buy it, so it's a 0. And what you can see is that technology 1 and technology 2, it's only valuable to the middle income country, and it's relatively modest globally in terms of health impact. Technology 3 is valuable to both, but in quite a modest way. It's technology 4 that's the real big winner, and it's most valuable in the low income setting. So we can see both the scale of the global impact and its distribution across different healthcare systems. Now that's the health impact, but as we've just seen, we can also express this in terms of the equivalent healthcare system resources for each healthcare system. It looks like that. So this is in money. Summed, the monetary value summed across these 2 healthcare systems. Similar kind of pattern. 1 and 2, only valuable for the middle income country. 3, valuable for both, but quite modest. 4, really valuable. And you can see how it's distributed. And because we've put this on a money scale, now we can consider whether Bill's upfront investment, imagine each of these development programs is going to cost Bill £20 million. We can now represent return on investment as circles. The reason why I don't like return on investment, it's another ratio, it's potentially misleading, but okay, the Gates Foundation likes return on investment. Okay, and they like bubbles, okay? They really like bubbles. Now, this is done like this because of Trevor Mundell, okay? He likes bubbles and he likes figures like this. The problem is that his bubbles and the figures they've done are all based on ratios, so, yeah, okay, don't tell him, but his bubbles are bollocks, okay? So, yeah. These are much more sensible bubbles. If you want bubbles, do these bubbles. I don't like bubbles and I don't like return on investment, but at least you can see the point. That we can compare the upfront, how much of Bill's money we're spending, with the financial value of what's happening actually on the ground in these systems. How am I doing for time, Tony? Okay. Tell me how much more people can put up with. This is the end of trying to persuade you that health opportunity cost is important. I just want to review the evidence of what we know about it.
We want to have a discussion.
We do.
So, yeah.
10 minutes?
Okay, max 10 minutes.
Max. So, I hate the term cost effectiveness thresholds. It means different things to different people. Effectively, it's just become used as a norm of how decisions are made. NICE has said since 2004 it's 20 to 30. They're lying. They don't say no to anything below 30. On average, they approve at 40. World Health Organization for a long time until very recently kind of promoted 1 to 2 times GDP per capita. Others think of thresholds and how much you're willing to pay for a DALI. It's really representing how much individuals' consumption they're willing to give up. It represents the demand side, often based on VSL or willingness to pay. But what we've seen is that we don't want, what we need is the supply side. what do we give up? Let me just very briefly show you something about estimates that are available. We've been able to do it in the UK, estimate the health effects of change in expenditure. We can have a look at the potential implications that that has for other healthcare systems with lower GDP per capita, and then more recently we've looked at the evidence of the health effect of changes in expenditure using cross-country data. The UK, I'm going to summarise 5 years' work in 2 minutes. Okay. We've got NHS expenditure allocated to disease area available at local level, PCTs, and also outcome data in the form of mortality at PCT by disease area. That means we can estimate two things. We can estimate how a change in expenditure gets allocated to different disease areas, and we can estimate how a change in spend in a disease area translates into a change in mortality. So we can estimate these equations. I'll take any questions about the econometrics. Sure, it's a challenge, but we've been able to do it. However, just looking at the effect of expenditure on deaths isn't enough. We need to know the impact not only on survival but also on quality of life. So we can express that as a proportionate effect on the burden of disease, the mortality burden of disease, and then apply that to a more complete picture of burden of disease. In other words, quality burden of disease. In other words, use mortality as a surrogate for the total effect of expenditure change. We can then extrapolate to these other disease areas, PBCs, where we can't directly estimate things because there's no mortality, like hearing, things like that. Mental health, there's a bit of mortality, but not really. And then apply that. And then we get a cost per quality of what the NHS is currently paying to avert equality. I'm going to be quick. Scores on the doors. Look at the bottom right box, that's what we estimate. £13,000 gets you equality. What is this telling you? It's telling the NHS is pretty damn good value. £13,000 gets you one quality. A lot better value than thresholds and other things like that. Do you think it's too low? I do. But if you think it's too low, vote for more taxes, vote for more public borrowing, vote for a massive reallocation of public expenditure. But that's what you voted for. The only problem is you didn't know it was £13,000 when you last cast your vote. Now you do. It also means NICE is doing profoundly more harm than good when it approves new drugs. We've been able to update that. I'm not going to go on about it, but I did want to show you this slide. It went up on our website today. We're re-estimating it for the Department of Health, and that's what it looks like for 10 waves of data. What's published, what was previously published to these 3 waves of data, we've re-estimated it at a different geography, and that's what it looks like. There's £15,000. And where NICE approves, which is at a minimum 30 and 40 and 50, isn't even on the figure. The probability that NICE is right is only very slightly greater than the probability that my first wife would behave in a reasonable manner. And believe me, that is such a low probability, you've got no idea. Okay, it's like, you can hardly see it. What about the implications for other countries? Well, if you think we've estimated this right in the UK, that's about 50% of GDP per capita. If we can only afford 50% of GDP per capita for equality in one of the richest countries on earth, for poorer countries, what do you imagine? Well, it ain't going to be more. Everything we know suggests that actually as you get richer, you're willing to spend a great proportion of your income on health. I'm not going to go through this, but there's a paper by Beth which looks at how you might imply what this might mean. And it suggests that 50% of GDP per capita is probably an upper bound on what this might look like in lower income settings. Not 3 or 1, but 50 or less. What else can we do? Well, there is a literature, quite a reasonably big literature, on trying to estimate the effective spend on mortality using cross-country data. All the work that's currently underway, not just in the UK, but across many other high-income countries to do this, is using the data. Don't have that. And a particularly important paper was Procurement. And he estimated, if you like, the effect of spend on mortality for 127 countries, not just low and middle income, but high income as well. And he did that on under 5 mortality and maternal mortality. And it was a good account for endogeneity, blah, blah, blah. It was really quite good. So what we did was to re-estimate it. Re-estimate Bakori's work, but re-estimate it for the impact on adult, male, adult, female mortality of those under 5, and then apply those estimates to baseline mortality rates across all these countries, age, gender structure. That means we can get a number of different ways in which we get to DALYs. We can do it indirectly, a bit like we did in the UK work. We just estimate mortality and then we use it as a surrogate on DALY burden of disease in those countries by age. Or we can estimate it absolutely directly so we re-estimated using the DALY estimates. We can, if you like, estimate the effect on YLL survival and disability, again, directly. So we've got 4 ways of doing it, just to examine whether this way, when all you've got is mortality data, is a reasonable approximation for when you've got the DALY data. And they're reasonable, they're in the same ballpark. So, this is what it looks like for low and middle income countries as classified, I believe, in 2013. This is 1 times GDP per capita, this is 3 times GDP per capita. The darker ones are what you get from the range in the Woods paper, which basically extrapolates our UK work using income elasticities. And the other ones are from Jessica's work. Now, we tend to get obsessed by GDP per capita. Actually, that's probably not the most interesting way to look at these data. A really interesting way to look at them is by under 5 mortality. And it's exactly what you'd expect. Very high under 5 mortality. Actually, your cost per DALY is really, really low, irrespective. Tony's getting itchy. I'm almost done.
Getting interested.
Okay, good, good. Good. So, I mean, just to say, we're in the midst, we have updated all these. So, the work for Gates, we're updating all these. We completely update, but we haven't quite written it off and published it yet. But we're all updated. It intends to project those. Demographics, projections of mortality, projections of healthcare expenditure. That's a bit heroic. But hey, we need to know what we think is going to happen to opportunity cost over a 20 to 30 year period to evaluate some of the big programs that have got very long-term effects. So we're going to have to do it. We're also going to incorporate the results of a meta-regression, and we hope to redo the meta-regression. Meta-regression is published as a work. So, there's loads of challenges with all these empirics. It's challenging even when you've got good quality within country data, as we do in the UK. It's challenging. It's even more challenging in other high-income countries where it's been done, like in Spain, Australia, Canada, Netherlands, all underway. They've got less granularity in their data than we have, believe it or not. So they face even bigger challenges. It's especially challenging using cross-country level aggregate data. But at the end of the day, this is an empirical question, and some assessment of this quantity is unavoidable. In fact, we make this assessment implicitly every time we make a decision. So, we ought to challenge it with some explicit assessment based on the evidence such as it is. I don't agree with academics who go diving for this. Get it past peer review in a particular. Yeah. So for me, it's about providing a useful start point for assessment and refinement. Do I believe they're true? No, but then again, I don't know what the truth is. If you want the truth, don't go to science. I don't know. So, final slide, what are the implications? For me, it's got implications for global bodies. Purchasing decisions and tier pricing, Global Fund. Development decisions, Gates. Recommendations, World Health Organization. For healthcare systems, and we've been working in Malawi with the ministry there, it's about improving overall population health, and they need to, this is useful in their attempts to do so. It identifies the real value of devoting more resources to healthcare. That's certainly been true in Malawi with their negotiations with the Ministry of Finance. So, on the, I'm sorry, just a little anecdote. Is that okay? Yeah. When we were on the way to Malawi, we were meeting the minister, and I realised I'd forgotten my tie, so I had to buy a tie in Terminal 5. I've never been shopping in Terminal 5 because it sells a whole load of stuff you don't need at stupid prices. And I had no idea that ties could cost so much money. Okay. I always wear this tie when I'm doing opportunity costs because I quite like the tie. But this was the cheapest tie I could find in Terminal 5, and it was £57. £57. I had no idea you could pay £57 for a tie, and it was the cheapest. Guess how much it cost to avert the Darwin? $61. Worth more than a Dali in Malawi. In fact, with this tie, you could buy a Dali and you'd have enough left over for a slap-up meal and 2 bottles of local beer at one of the bars in a long way. That is shocking. So for me, telling it like it is partly about contributing to accountability of the current arrangements as we find them, internationally, nationally and locally. And not just in low and middle income countries, but in high income countries as well. You know, if we think about the difficulties that we have in the UK with a very well-organised and well-funded body like NICE trying to make these decisions, and the way in which that is difficult for that institution, then just think of what the political difficulties are in low-income countries. You know, and the Minister of Health in Malawi is doing a very brave thing. But really importantly, including the opposition and the shadow minister in all those negotiations and setting it out as, look, what we all care about is Dalis, so what are we going to do? Anyway, I'll finish there.
Well, I think some of you might have found that a bit of a gallop across an enormous amount of work over the last, 10, 15 years? Yeah. Tremendous. I mean, questions. Now, don't be afraid if you wanted to explain something that you didn't quite understand, don't hesitate to ask for an explanation. Similarly, if you want to challenge him, challenge him.
Yeah, definitely.
Just don't sit there and say nothing.
My question is around the thresholds in low and middle income countries, because there is a gap in knowledge and people are desperate for these country-specific thresholds. And so the work you're doing here is potentially so powerful. At what point do you say we just don't have good quality or enough data to give you these numbers and you need to find X, Y, and Z rather than produce the numbers and then question them? Because it's really hard once these numbers are out there when you're trying to talk about technologies to not try and align to these thresholds. They're so powerful.
Yeah, I think that's a very fair point. It's a balance, isn't it? I don't believe academics should simply hold up their hands and run away and say, oh, we don't know. These decisions are going to be made. There is some evidence out there. Actually, there's some quite good evidence. You know, there's over 60 studies that have looked at the relationship between health. Demonstrated that we can sensibly link that to DALIs, and we've been able to compare that, if you like, sensible linkage with assumptions to what happens if you directly estimate the DALIs, and they're pretty similar. You know, in some countries it's over, some countries under, but you're not a ballpark out. So I think we're at the point, I think the numbers we've got are valuable, and the way in which we've used them in Malawi is not to say our central estimate is $61 per DALI. That's it. You don't need to think about anything else. What we said was, okay, at the minute, this is what we think the evidence suggests Malawi is currently paying for a DALI. It's kind of what your healthcare system can afford. Let's design a package based on that. And let's have a look what that package looks like in terms of the total spend envelope. When we've taken account of constraints and you can't implement everything and all the rest of it. And actually what it showed was it's pretty ballpark to what their envelope looks like. Now, does that mean we say $61,000 is the correct answer? No, it means that once we've done the work to think about how you would reorganise the essential package of care, your new threshold, or health opportunity cost, becomes the last thing you put in, or the thing that you would put in if you had a little bit more money. So I don't see it as, like I was saying, I don't think they're decision rules. You know, it's one number and it's done. And I certainly wouldn't want us to contribute to a kind of thoughtless mantra, the way that the 1 to 3 times GDP has effectively been used. That's definitely not the plan. What we're trying to do, as well as provide some numbers, is to provide the reasoning and the rationale and how you would update it and what you could do with in-country data.
When you say
and one of the things is to do the process in Malawi, which is to construct the package.
when you say we, Carl,
We.
who
Who are we?
are we?
Right-thinking people around the world.
No, but in Malawi, who are we?
In Malawi, who are we? In Malawi, it's York and the ministry.
Which ministry?
Ministry of Health.
Only health.
Ministry of Finance are involved. I mean, our role initially was to provide a kind of ideas and framework about how they would start to construct their essential health package. 2 of the key senior civil servants are my ex-students, and Paul Revel, who's also worked in Malawi for many years, is close contact with them, and they kind of asked if we would kind of help in a way. As we started to help, it became apparent that they really wanted us to be more involved, so we did do that. But we were very clear at the outset that our job was to help put in place a framework, but then it was handed over to the ministry, and they had the support from ODI, ODI Research Fellow.
The reason for me asking this,
Yeah.
it's been really building on this question of the adequacy of the data, is if I understood you correctly, it's you're saying that this isn't, as Alan Williams always used to say, this isn't a substitute for thought.
No!
This is a way of helping people to think through very difficult problems with a lot of uncertainty, and it requires a number of different sorts of people at the table.
Oh, yeah, absolutely.
And so there are some sort of organisational implications for the way the decisions are taken. There was somebody here who wanted to ask a question.
Hi. So I noticed that you use a lot of mortality data, but as we all know, there are so many other outcomes that matter to patients, to the healthcare system and everyone else. And I was wondering, how would you go around, or how would you go about comparing those outcomes and costing them? So for instance, how much is a diabetic's foot worth versus their life? And yeah, I wondered if you could just speak a little bit about that.
Okay. In the UK, the only data that we have available that's complete across disease areas and available at a local level is the mortality data. And as a consequence, we have to make assumptions to link that to QALYs, totally agree, mortalities, at best a surrogate for health, which includes all those issues. At the moment, there is problems data in the UK, and we have analysed the problems data, but it's a tiny, tiny sliver of 1 PBC, tiny. But what we've shown is that the same statistical analysis can be applied to those data. We're in the midst, at the moment, of doing a elicitation exercise with clinical experts, formal elicitation, around the assumptions required to link to quality of life and duration. On the question about quality of life and how we should weight these different aspects of different diseases, we can go in one of 2 directions. We can have a health state classification system, which is what a QALY is, or a DALI, really, and then weight each of those states relative to full health, ideally by asking individuals, either the community or patients, choice-based questions. How much of your life expectancy would you give up in order to move from this particular state, which involves a lot of poor quality of life, to full health? And the proportion of their life expectancy that they're willing to give up is effectively the weight. Now, I believe those kind of questions are the most appropriate, because that's in effect what we do when we make decisions. If we say there's a lot of qualities associated with fixing this diabetic foot and therefore we're willing to pay a lot of money for it, the consequence of that is there will be increased mortality and reduced survival elsewhere. And the only fair way to ask that question is to ask the beneficiary, well, okay, somebody else is going to have to give up life expectancy for you. How much of your life expectancy are you willing to give up? And that's the way. I mean, I could amplify on that, which would allow me to get in another dig on my first wife, which is about patient versus community preferences. Maybe that would be inappropriate, but.
It was very good presentation. Thank you for that. I have a question on one of your slides about the value to healthcare system. So I was wondering how you value this. So what do you mean by the definition of value, and how do you estimate it?
I'll go back to.
Can you hear the question?
I think so. Oh, maybe. Okay, maybe this bit. Yeah. So.
It's more like a, like a money terms.
So the way it works is like this bit is the health effects. Health gained, health lost. We're all happy with that. Net health effect, taking account of the these benefits, we can afford to pay up to 40 million. This intervention, it's only going to cost us 20. So we can represent that as a net gain in health, or the equivalent net gain in resource to the healthcare system. Because if we just gave, let's say we didn't invest in this intervention, but we gave the healthcare system $20 million extra dollars, we would get the same health benefit of $100,000. Nice thing here is that we are able to get it into money, but this is really important. This money is not just any old money. This is healthcare system money. And that's not the same as money in somebody's pocket. The two are very different. Yeah? Because generally speaking, public money is scarce relative to consumption. Private consumption might be scarce as well, but you know what? Public money is even scarcer and more valuable. And in fact, that's represented in what we know about how much people are willing to pay to improve their health. So we're estimating around about £13,000–15,000 a quality. The wide literature on figuring out what people are willing to pay, it's very wide, okay, but about 30 if you're going to take something in the middle, about 30,000. So people are willing to pay 30,000, the NHS is delivering 15. What does that tell you? It tells you two things. Our healthcare system is not meeting the expectations and desires of the population. They are constantly disappointed. And it's also telling you that a NHS pound is worth 2 consumption pounds. I know that's kind of an NHS example, but in many respects, it's probably even more extreme in low-income countries where it's particularly difficult to finance healthcare systems. So a pound in the Ministry of Health, a dollar in the Ministry of Health is worth a lot more than a dollar outside the Ministry of Health. Is that okay?
Or in other words, the NHS or most of these systems are seriously underfunded.
Thank you. I had a question because you were mentioning Gates, their metric of lives saved. If you had anything to say about how that relates to what you've been talking about in terms of Collies or Dallies. Do you, yeah, sort of just maybe a bit more background for me or us on that metric they use and where it sort of, how it relates to maybe some of what you've discussed.
Okay, I haven't got it for low and middle income countries, but I can show it for the UK. We could crank it out from our work, we haven't done, and there's a reason for it. So, from our basic statistical analysis, without doing any more extrapolation, we've got an estimate of how much it costs the NHS to avert a death. Over £100,000. Now this isn't any old death, because we're averaging 3 years of mortality. These deaths averted must have been averted on average for at least 2 years. somebody's life is ever saved, death is merely delayed. And the key question is, how long did you delay it? So for me, I'm not particularly interested in the cost per death averted.
Quick question about the international work. Were you able to break down expenditures into different financing sources, or is there a way to implement the strategy by looking at the marginal impact of each financing sources on outcomes?
Ideally, that would be really cool. And there are data issues.
Last one, I guess.
Thank you. It kind of picks up from that thought about the conflicting and interfering factors. Where do both spend and interventions that are outside the immediate healthcare system come into it? Yeah, sort of start wherever, either like as easy as community care and sort of housing, road traffic, sort of.
The important thing is to respect where those costs fall. So insofar as, okay. So for projects which have got effects on different we're affected another form of public things that affect and reflect where they fall. So insofar as it's on healthcare, what we're replacing is health. It's on health opportunities. So the dollars for consumption are just consumption dollars. Dollars in the healthcare system are not the same as consumption dollars. And we need to idea of the health. Wherever those effects fall, we can convert into the equivalent consumption. Basically, we want to know what are the health effects, okay, and what are the costs in a common metric that we respect. Right, yeah, no, absolutely, really good question. Right. Healthcare sector is one of the few sectors where we've got this far in terms of figuring out what the effects of marginal changes in expenditure are. And in fact, the Department of Health, when they took these estimates to Treasury in the last public expenditure round, Treasury said, excellent, why don't we have this for our other spending departments? Quite right, it's exactly what Treasury should be asking, but we don't have it for the other spending departments. What can we do? We don't even know actually how to get an outcome measure for most spending departments. It's only in health, because of the scrutiny that we've been put under, that we've pushed the envelope of thinking about how to measure health outcome.
Well, in 1970, I was told by a lot of people that you can't do it in health, right?
Yeah, absolutely. No, it doesn't mean it can't be done.
Yeah.
In the meantime, if in health we know it's 15 people who pay 30, we know in health the ratio of the value of public to private pounds is 2 to 1. Government, you'd expect them to have equalised. A reasonable start point would be to say, you know what? No, we don't know what in education, defence and criminal justice. That's a start point, to start to bring all these things. What we shouldn't do, which is what's imagine that
been a long-term aspiration. I think that's it. You need to get home for tea, I guess. So, Karl, thanks very much. Wonderful exposition.